I want to move on very quickly now to our next set of speakers, Eberhart and Alex, who are going to focus on primary healthcare in poor urban neighborhoods in Brazil, as I'm sure most of you know, which are called favelas. So over to you guys.
Thank you. First of all, thank you for inviting me to participate on this. My role here is really to introduce the next speaker, Eberhart. Before that, I would like to call attention to a few points. Brazil is in the front line as the first very large country in the developing world to face the brunt of these pandemics. We are today reaching 1,000 deaths, and this is no measure, just a little bit of what is going to happen in the country as a whole. A country that is characterized by increased inequalities, a weakened health system after years of neglect by the government, a very poor science literacy starting from the very top. Our president doesn't understand what a flu epidemic is. Therefore, contradictory messages coming from the government and confusing everybody. A high-risk group that I would sustain cannot be defined by cutoff age because comorbidities in Brazil start well before 60s. We have people that are aged 40, 50s with comorbidities from diabetes, cardiovascular diseases, hypertension, and so on. And all this with pockets of poverty that we have just heard from the previous speaker, very similar to South Africa. We have now the first deaths in the largest favela in the country, Rocinha. And that is exactly where we have our next speaker, Eberhart Portocarrero-Gross, my good friend, a young GP that is fully devoted to work in Rocinha in very tough conditions. So Eberhart, I'm delighted to have you here, reminding you that the pandemics here will have a very different face. It will be younger, it will be more female, it will be poorer, it will be with more inequality in the context of, sorry to say, messy messages from the government.
Can I just interject, and you will have 1 extra minute? I should have introduced you both properly, not just by your first names. I'm very sorry about that. I'm particularly, well, both of you in different ways. You know, we're very lucky to have you. Alex used to be the head of aging in World Health Organization and is currently the president of ILC Brazil, the International Longevity Center. And Eberhart, I don't think he has lots of grand positions, but he is the person that really matters, I think, at the moment. He is a clinician who is on the front line working in deprived neighborhoods, and his time is precious, and he is a real coronavirus hero because he is putting himself out there just about every day. So it's fantastic to have both of you. You have an extra minute. Eberhart, sorry.
Thank you so much. Can you hear me properly?
Yes. Yes.
Good. Well, so the idea here is to give some perspectives on primary healthcare for older people in Brazilian favelas. And the main thesis is that just as elderly patients with chronic illnesses are at a higher risk now, Brazil's chronic problems are making it worse and more, and are turning the country and putting the country in a more vulnerable position in this epidemic. So it's an honor to be here with you, and let me start by trying to illustrate this. Let me tell you about a patient of mine. Her name is Maria. Maria is a 62-year-old woman who works as a cleaning lady in a middle-class household. Her husband left her 30 years ago with 3 small children. She's illiterate, she has hypertension and chronic shoulder pain. She's been coping with depression for many years now. She's been trying to file requests for an early retirement for a while, but with no success. Everyone says it's getting harder and harder to retire in Brazil. She lives in a relatively good house for the neighborhood. 3 rooms for 4 people. Maria, her schizophrenic son, an unemployed daughter, and a 12-year-old grandson. Sometimes there's no water to cook or wash. From her only window, you can see the neighbor's window, a meter away. Her neighbor has tuberculosis. Now there's this COVID thing. Everyone's talking about social distancing and all these other measures. So that's a new part of it. Everything else has been there for a while. And as you've probably guessed by now, social distancing will not be easy for her, nor will the other protective measures with mostly imported from countries in Europe. They're not really adequate to Maria's household or to her neighbors. It's hard to ask of her to wash her hands every now and then if there's no water. It's very complicated to ask her to use alcohol when there's already a shortage of alcohol in the supermarkets and it's getting more and more expensive to buy some. And regarding her grandson, online schooling will probably not be easy in an unconducive environment with bad connection to the internet. And well, I think you can get the picture by now. As in South Africa, in Rio, there are two worlds which exist quite literally side by side. And in an unequal society, every measure we propose will have an unequal cost to its participants. It usually happens, the least favored ones will bear the highest burden. If the burden to the society as a whole is very heavy, it will probably be unbearable for its most disadvantaged members. Being an elder in this pandemic is an increased risk. And always, being poor is an increased risk, a health risk, a risk for basically anything you can imagine. So we here have to think not only of the older adults, but of the older and poor adults. Illiteracy, of course, is a huge problem. She will not be able to read the big posters we've put up about coronavirus. She won't even be able to read the memes online about it. Transportation inside and outside the favelas has always been a problem. She has to take two different buses to get to her work, and the buses they were a little bit more empty in the first week of the pandemic growth here, but it's already they're basically all back to normal and they're crowded again. Well, not instead of housing, will really self-quarantining, if it were possible, in a crowded neighborhood like Rocinha, will it make it less or more likely for transmission to occur? Same thing happens with tuberculosis. Rocinha has one of the highest tuberculosis rates in the world. And one of the reasons is the houses are all one next to the other with poor ventilation. So if tuberculosis, which has a big incubation period, an R0 which isn't that big, is spreading and maintaining its grip on the community for so long, what to say of COVID-19? We sometimes wonder if that should be a different strategy instead of quarantining at home. Also, extended families, multi-generational households are a problem there. Maria used to take care of her elderly mother, who has died a few years ago. She used to be a caregiver for someone who is even older than her. Which brings us, of course, to the gender bias, which is very present in this epidemic. Women, again, elderly, poor women, will bear the burden, because there are many times there are those who put money inside the house, those who take care of the children or the elderly, they'll be more exposed and will be more likely to expose others. And also, there's a race bias, of course, which goes hand in hand with the economic problems. This following week, after many requests from the Brazilian Society of Family and Community Medicine, the Ministry of Health of Brazil will now start looking at the race of those infected with COVID-19. And then we'll probably start to see a grimmer picture. There's also domestic violence. It's not a problem in Maria's household. She's, I should say, not in any way the most vulnerable of my patients, just a typical case of someone who lives in Rocinha, not someone I chose specifically to impress you. It's just normal 60-plus-year-old woman who lives there. In her household, there's no domestic violence, but in many others, right close to her house, there are lots of domestic violence. And what does that mean for staying at home? There's also lots of financial insecurity, and this does happen in her place. She cannot stop working. It's not really an option for her. She won't have the money to pay the bills by the end of the month. Because of like hers, the stay-at-home hashtag, or stay-home hashtag in Brazil, is turning into the stay home if you can. Because it's not reasonable to ask for everyone to stay home, unfortunately, at least in the way we're organizing now. They'll suffer tremendously from the economic crisis that will ensue, and actually is already starting, if we do not act appropriately. Drug use, suicide, homelessness, food insecurity, these are all old problems which will rise up again as the economic crisis grows. They're likely to get much worse. But still, surprisingly, some still hold the idea that this is some sort of democratic virus. I'm not sure if this plays out in other parts of the world as well, but in Brazil, some say, no, this is a virus which affects both rich and poor. It makes no distinction. This cannot be more wrong. It might be so that it affects both rich and poor, but definitely not equally. It was brought to Brazil by the rich who traveled to Europe and the United States, most of whom have had and will have access to all means of health support. But it is also a virus that will kill the poor, who will die undiagnosed. Which brings us to the healthcare system itself, the place where I work, and its shortcomings. Regarding statistics, we're now only testing the critically ill. This is giving us, of course, wrong impression of the way the infection is spreading. There are so far not enough tests, not enough money to buy the tests. And so, again, it's hard to organize based on unfair data. Some estimate our curve is actually growing like Spain or Italy's have. But unlike them, we have what we call sanitary voids, places where there's actually no sanitary equipment, no primary healthcare facility, no hospital, no walk-in clinic, no emergency and urgency department.
Sorry, Eberhart, 3 minutes.
3 minutes, thank you. Sometimes the only sanitary equipment, as we'd say, is a primary health center, but not always. Also, we've always had crowded hospitals. We've been enduring financial and admin cuts in primary health care for the last 3 years under the current municipal administration. There are less and less personnel, less community health workers, which are a bit of our treasure here, but they're being cut from the system. Now, on top of that, there's a shortage of professionals who are either symptomatic or are considered high-risk groups, pregnant women, those with immune diseases, and of course, those who are above 60. Strategies have been proposed like telemonitoring, which is quite good for vigilance. But we should say in the last 2 years, in my unit, we have had no telephone. It has been cut because of lack of payment from the municipality. How can I consider bringing my patients, doing a video consultation? House calls used to be dangerous because of drug dealers. Now they are also dangerous because we fear spreading the disease. You can see the numbers of the infection, even though the statistics are flawed, are rising. The municipality and the whole country actually is already announcing a lack of PPE, of personal protective equipment. We started to buy material with our own money in my practice. We're fearful for patients and for ourselves who are going to the practice every day. There's an emotional burden upon the healthcare workers with no support apart from some discoordinate initiatives, mainly by private individuals.
One minute, Eberhart.
Not to mention the no problem. Not to mention the future health consequences it will have for the patients we are caring, not directly related to COVID. There's also the elderly who are most likely to have a heart attack and finding an overwhelmed system which won't be able to accommodate them. Again, it's an uneven burden. Maria hasn't had a cough and fever yet, but I'm fearful she might. I'm also having a hard time to help her out with her depression, and I'm worried about her financial security. What kind of support will we have for her? We've been failing her with all her problems for the past years. We need a specific type of community-oriented care. We need a favela-oriented care. The way we organize as a society, both locally and globally, has actually brought upon her many of those problems. We have to think this over. We have to think over the way we're organizing. Will it be a stronger welfare state, stronger than ever before, or a different model we cannot envision yet? I don't know. It does seem we now have to find ways of dealing with both new and old problems at the same time. I hope this initiative, starting with this webinar, is a good start. Thank you very much.
Thank you, Eberhart. Peter?
Yeah, thank you both to Eberhart and to Alex. And there is an awful lot for us to think about from your talk. Story of just one woman in one neighborhood, I think, tells us an awful lot about much wider impacts of coronavirus on the least advantaged members of society in Brazil and in all low and middle income countries, as well as actually in the high income countries. It raises so many issues, so many difficult challenges, which predated the crisis but will become exacerbated as the crisis deepens. And I think it's clearly a massive reality check for the rather idealized approach that some organizations are taking in terms of providing guidance for primary healthcare and other areas to deal with this. So I won't forget the story that you were telling us about Rocinha. I want to bring in Meredith Wyse now, who's based in the Asian Development Bank and is based in Thailand. So we're really going all over the world in today's session. And Meredith is going to provide some Asian perspectives, and of course, Asian perspectives are very relevant at the moment on coronavirus, with a particular focus on how primary healthcare services for older people need to work together very closely with social care provision in the community to have an integrated response, because clearly the divisions between primary healthcare and social care for older people at the community level exist much more in the imagination of policymakers and in the reality of day-to-day practice. So Meredith, over to you. I don't think your camera's on, so if you could turn on your camera and your microphone. Hi Meredith, we can't actually hear you at the moment. Is your microphone on?
I'm sharing Meredith's presentation, but she had a problem with the connection, but she is back. Yeah, she's back. Meredith, are you with us?
Meredith, would you mind calling Lucas on WhatsApp, and then you can still talk through your slides, and he will simply relay the conversation on loudspeaker from his mobile phone. Thanks.
Hello. Meredith?
While we're waiting for Meredith, and I will stop as soon as she comes online, just to make full use of our time, there are a couple of points I was going to raise towards the end in moderation, which I think cut across the presentations we've had so far. And clearly, inequality is which all speakers have referred to. And there are lots of different elements to inequality in coronavirus. In high-income countries, there's a lot of concern about inequality between older people and younger adults, between generations. And this has really been brought to the fore by what's been going on over the last few weeks. And to some extent, one can see a discourse, which I'm not very comfortable about, in terms of society as a whole making large sacrifices just to keep a few older people alive who would die anyway, and a sense that these tend to be groups who've had very privileged lives, who've got privileged access to resources, which are denied to younger groups. And that's been very much the focus, a very uncomfortable focus of the discourse in high-income countries, and it would be interesting to know if that's also the case in low and middle-income countries. But there's the other dimension of inequality, which is inequality within populations of older people. And of course, Brazil and South Africa are both countries with very high levels of overall structural inequality among people of all ages, and they play out just as acutely, if not more so, among the very old. And we've seen some examples of this, particularly in Eberhart's talk, in terms of patterns of comorbidity, of specific forms of vulnerability, of literacy, and clearly, with bearing in mind our particular focus, very variable levels of access to adequate primary healthcare services, health posts which don't have medication, don't have PPE, that don't even have telephones. So I'm going to leave a question with you, which we'll come back to in a discussion session, because I think Meredith may be getting online. And the question is, clearly, we know that the impacts of coronavirus will be shaped very much, on older people will be shaped very much by these complex inequalities. And we expect that they will tend and exacerbate many of these inequalities. It would be very interesting from all of our three speakers to get one specific suggestion about how primary healthcare might possibly be able to mitigate this effect. So I'll leave that out there, and that gives the speakers, apart from Meredith, a little bit of time to think about it while Meredith gives her talk. Do you know whether Meredith is now able to
Yes,
talk to us?
I think she's able.
Hello, Peter. Can you hear me?
We can hear you loud and clear. So I'm going to mute my microphone now and leave the floor to you, Meredith. Thank you.
Are you seeing the presentation, Meredith?
I am, Lucas. Thank you.
Okay, perfect. I'm gonna be running for you.
Okay, we can go on to the next slide. Very much, Peter, and apologies for the technical issues on Friday evening here. And with this limited time, I'm just going to highlight a few considerations, as Peter said, related to primary health care, social care. But I'm going to try and look at some of the resources that especially Asian countries have to pull on in this time of crisis. Obviously, Asia is a hugely diverse region, over 900 million older people, as Leon highlighted earlier. So some of these comments will be generalizations, but I hope to pull on some concrete examples as well. One of the key challenges that obviously we're having at the moment is really, and I think this is a global challenge, is the lack of attention to this issue of how older people are being affected by COVID-19. Obviously, ministries of health are very, very heavily focused and working very hard, but with a strong effort on the response in terms of getting equipment, ventilators, treatment, prevention measures. Ministries of social welfare are very heavily involved in ramping up their social protection measures, especially their social assistance programs as well. So actually getting on this, which I think is why it's so important that collaborating to really raise and re-emphasize these issues. Saying that, of course, we know older people and people are always hard to get onto the end of government as well. That is changing in countries in Asia due to the rapid aging, demographics, and a lot of advocacy and society and media and research work that's been going on. So are very positive trends. And is of course preparedness. Asia, there are far too stories in Asia. Of course, there are some countries that did have a pandemic preparedness response. Korea, Taiwan, and Singapore related to how it responded, considering primary care and aged care facilities. That coming through the experience.
Hi, Meredith, the sound quality isn't great. Can you try and be a bit closer to the microphone? Thank you, and sorry to interrupt.
Sure, I might turn off my video if that's okay, otherwise you'll see my face. Okay, is that better, Peter?
I think that's clearer, but you need to do a bit of talking for me to be able to really judge.
Okay. So I was just highlighting that there has been some very good preparedness highlighted in some of the Asian countries, South Korea, Taiwan, and Singapore as well. Singapore, as soon as there was some community transmission, they upgraded their alert, and that really put into place all their preparedness plans, including guidelines on services, which ones to take off, which ones to stop, access to a centralized source of PPE, etc. So really, the lessons of preparedness are being very much seen in this region. Another challenge is reaching older people. Of course, over the last decade or so, there's been huge progress in access and affordability to
Meredith,
healthcare.
just one other thing. Are you still on slide 1? Because Lucas is wondering if you should be moving the presentation along, the visual part of it.
Not yet, no. Key challenges.
I'm so sorry. I'm so sorry.
Okay. Of course, reaching older people is always a challenge, even though there's been huge progressions in Asia. And of course, with all other places, there's limitations on resources, human resources, equipment, supplies, and finance. Next slide, please. I just really wanted to highlight that in Asia, there are quite a lot of resources to be built on. This graph that you may or may not be able to see indicates the relative number of doctors and nurses across a number of Asian countries and yes, Asian Pacific countries. And you can see the numbers of available healthcare staff are limited. However, what many countries in the region have done, which can be utilized in this crisis, over the last 30 years, they've built up strong community health workers systems. Thailand has nearly 1 million village health volunteers. Indonesia, over the last 10 years or so, has trained up 1,000 cadres in the communities with a specific focus on supporting older people. They've trained up 55,000 people in the community to support family caregivers. And over the last few years, there has been an increasing focus on using these community health workers to respond and to support older people. And these can be utilized in this crisis with tasks such as education, referrals, care and supporting families. And as we've seen in this crisis, it's not just a health crisis, they can really support linking older people to other services as well. Next slide. Again, something quite characteristic to many Asian countries is really the very, very strong role of community-based was highlighted by Leon as well. In many Asian countries, there are community-based organizations that have a focus on older people. Thailand has nearly 10,000, I think. These pictures are from in Vietnam, where there's over 2,000 of these intergenerational clubs. These clubs tend to provide a range of services and support and engage older people in many, many ways, from food security, income security, and really accessing health. And they have really been mobilized in this crisis to get prevention measures, to get basic needs, to continue to provide home care to people who are not receiving home care, and of course that monitoring which can support the primary health care response. Next slide, please. Long-term care in Asia. We've seen with horror these stories coming from many countries about the infection rates and mortality rates in residential homes, and this has already been raised. Obviously, this is of high risk in Asian countries. There's a very weak regulatory framework. We did a study on long-term care in a number of countries about 2 or 3 years ago, and the regulatory framework, many care providers were asking for a stronger regulatory framework. We know that staff skills are limited and they had a lack of training, and has already been highlighted, they are vulnerable themselves. And of course, quality management frameworks are again weak, even basic infection controls. So there is a very high risk for people in residential settings. Just a couple of caveats. While numbers are all relative, the numbers are much lower than many of the OECD countries. I think in all these countries, 6 countries we did a survey on, it was less than 0.1% of older people in residential facilities. And also the health status of people in residential facilities is higher than you would find in Australia or the US or so. So while they are still high risk and they need to be engaged, there are some, well, not bright points, but yes, different circumstances to be considered. What this does mean, though, is of course that older people are cared for at their homes by their requires supporting those families in this time. As already been highlighted, these families are, everyone is under stress at the moment. Crowded homes, lack of income, having to care, lack of jobs. And so family carers really need to be engaged in this, in good education, psychosocial support, basic needs to be able to continue care. This also needs really positive messages on what they can do around nutrition and exercise and really maintaining the health of their loved ones. Of course, there are still some really key spouses provide a lot of care from the primary caregivers, and they are obviously at high risk as well. There are increasing numbers of people living in Asia alone, and often this is females who are also at risk. The data shows that when care is needed and functional, there is a functional decline, they do tend to move back with their families, but of course that is not an option for everybody. So again, very high risk. So the need to support family caregivers is key. Just the last point I want, and I'd like to, I really phrase the post-COVID situation. Next slide, Lucas. Not just a post-COVID, but maybe post-first phase COVID. I think we need to start thinking soon about how we see primary healthcare for older persons adapting over the medium term in periods of maybe extended social distancing, or when there is still risk of community transmission. How will older people access primary care, not just now, but over the next year or two? And what changes in the systems and services need to be done to modify to allow that? Might need to start thinking about what do the role of primary care and what will be the changes that will happen as a result of this crisis. This is rather an optimistic slide. Of course, this is not guaranteed and it will take concerted effort to move it forward. But I think this crisis has really reinforced the role of primary and community care and really highlighted the importance of hospital care being used. We know many older people do not use primary care and go straight to hospitals, but this crisis has really indicated the need to utilise the primary care system appropriately. Expansion of coverage. We know in many Asian countries, well, globally, that primary health is not always set up and is not of the older population. Don't include some of the key treatments that are needed, and perhaps through this crisis we can start seeing the need to include more preventative care, affordable, and so forth. Working in this new way, this new society, we might really start seeing investment in some of the IT enablers, information systems, healthcare, and telehealth and tele. A huge emphasis has been to recognise the lack of the health workforce and the need to really work on that quickly and to be able to provide care for older persons. I think what this crisis is showing already is really demonstrating the need of care, really look at the various aspects of care and bringing that together, and hopefully that will remain. As Peter said, the pipe dream of integration of health and social care is this going to be a time when we are forced to work together and collaborate. And what we have seen, I think this crisis has seen, is everyone is being pushed to collaborate because that is what's needed at the moment. But how we can build on that to make sure that that collaboration works and goes forward to provide better care for older persons going forward will be interesting to see. Thank you.
Thank you so much, Meredith. That was, again, a really great presentation, and I think it really complemented the other talks you've had, both in terms of the regional perspective and the different issues that you were raising. Now, what I was expecting was that my colleague Janet Seeley from the London School of Hygiene and Tropical Medicine would manage our moderated discussion, and we've got about half an hour for this. Unfortunately, and this is the nature of the crisis, Janet's just had an emergency need to make an emergency conference call to colleagues in South Africa, so she isn't able to participate as a moderator. So I quite nobly have jumped into the breach, and I'm going to do my best to try and moderate the discussion and the questions that have already come in. So I've already been sent some very interesting questions. But I would encourage those of you who are out there to send us any questions or comments, send them to Lucas, and we will do our best to include all of those in the remaining time that we have. Before I start taking questions from participants, I just want to briefly go back to each of our speakers for them to give one short, sharp suggestion. By the way, Alex Kalache, at the moment, his mic isn't working, so I will field Alex Kalache's suggestions via WhatsApp. But I would like one short, sharp suggestion about how primary healthcare might make a specific contribution to reducing this interaction of inequality and coronavirus, both inequality adding to the effects and contributing further to inequality among older people in the settings that you're familiar with. So over to you guys. I thought I'd start with an easy question.
Okay, well, so can you hear me, Peter? You can hear me. Okay. I'm not sure that I can give you an answer to how can primary care be improved or what needs to be done. But I do think that what this virus has highlighted is the need for a global response. It's a global virus. The virus doesn't know any borders, and the impact on different sectors of the population, old, young, poor, rich, are very profound. And I think the only way to resolve this is to strengthen global institutions to actually deal with this in a global way. And we need to, if we're going to try and
get local solutions to problems, I don't think we're going to be able to resolve it. I think one of the things that I've really been thinking about in the last few days is if we have a crisis where there's an earthquake in a certain part of the world, immediately the International Red Cross mobilizes a massive rescue force and sets up field hospitals, etc., and to deal with a crisis like that. I don't understand why we can't, as a global village almost, know where the pandemic is. It's going through phases of waxing and waning, and we can mobilize very quickly groups of healthcare workers, and we can mobilize the resources, whether it's ventilators, field hospitals, etc., to move into countries where we can actually start doing rapid testing, we can start identifying people and treat them there. And I think that's possibly the way we need to go. We need to start saying, we need to start working more at a global level. We need to enhance the global institutions, not destroy them. And we need to work together in a transnational way.
Before you reply, Eberhart, I just want to throw in a comment that Alex actually sent to me, which I think links into that. He was talking to me about global inequalities, in that, as we know, before coronavirus came along, there was a drainage of health care resources from poorer countries to richer countries, in terms of workforce and in other ways too, and that's been very much brought to the fore in terms of the tragic deaths of all health workers are tragic, but in the UK, many of those health workers are from the global south, are migrant workers. And he was asking, how can we both draw attention to this injustice, but take steps to try and resolve it? And I guess what Leon was talking about is quite closely related to that concern that Alex has. It would be a very proactive way to deal with it. I'll give Leon a chance to quickly respond to that, and then I'll come back to Eberhart to answer the initial question. Okay?
Yeah, I mean, the global south has seen a massive drain and the flight of intellectual capital and resources, etc., to the global north. I think we need to start looking at redressing all these issues. But I think we've got an immediate problem that needs to be resolved, and we need to deal with it in an immediate way. The big problem with this, with coronavirus, the way I see it happening, is that the disadvantaged and disenfranchised within communities are going to be suffering, but certainly within countries are going to suffer very significantly. South Africa is in a 5-week lockdown. Our the wheels of economies have come to a standstill. We don't know what's going to happen in a year or two, where we face massive unemployment, social unrest because of people not having jobs, the economy having to get restarted again. So I think we need to look at this in a global way, to say we need to make sure that countries are supported to get back on their feet. And the only way I think we can do this is from a global way, whether it's healthcare personnel, whether it's support in terms of getting the manufacturing industries, the supply chains back on track, etc. But we have to get people back to living their lives again.
Eberhart, and then Meredith.
Yeah. Well, of course, I agree. Most important solutions are at the global level, and they'll have to do with the economical and social structures we've put ourselves into as a global village, as Leon says. Nevertheless, if primary healthcare is well equipped, I understand mitigating inequality effects is what we aim for all the time, even before COVID-19. At an operational level, I think we're in a very good position to be a bridge between these global initiatives, those large picture actions, and the local characteristics, because depending on where you are exactly, some things which are very well thought for the global level will not be easily implemented. And so the places where you'll have to change a little bit of the original plan will have to be seen by someone who works on the front line. And I think that's a place where well located. and then providing local information as feedback for those global initiatives, integrating with social care, maintaining care for chronic conditions. Provided we have the human and material resources to do that, these are partly old solutions which have not been implemented for all problems, but again, that might start to really happen now if we unite our efforts globally.
Thank you. And I just want to abuse the position before Meredith chips in, because I think that final point you made, a lot of countries, including Brazil and South Africa, do have enough money to have a decent universal system of primary health care. The problem is that they weren't putting enough of resources into the health service, and they were putting their healthcare resources into the wrong services. So the fundamental ideas of Almata and universal health for all that first came on the scene in the 1970s are all the more relevant today, I think, than they were. So yes, on one hand, there are global injustices and inequalities about the way health resources are allocated. But actually, notwithstanding that, apart from the very poorest countries in the world, we have the wherewithal to do an awful lot more than we're doing. Meredith, sorry for butting in there. Over to you.
Well, Peter, you kind of preempted what I was to say, but yes, I think we've already seen across the globe the differential between treatment and access to testing between different sectors of society. I really think, yes, greater emphasis on UHC and the allocation.
Sorry, Meredith,
I think.
your microphone isn't great. Can you get as close to it as you can?
Okay, Peter, I was going to say, I think you've preempted what I was going to say, but I think it's going to be the recognition of the importance of really expanding universal health coverage for all. And like you say, the decisions being made on what to resource, I think that's going to come up. That's going to be one of the quickest, or one of the, hopefully the most ways that health can really support reducing this inequality.
Thank you for butting in. I'm going to move on to a related question, which links in quite strongly. This is referring to Meredith's talk, where she talked about the have quite substantial primary healthcare infrastructure in many, apart from the very poorest low-income countries, including community health workers. And that's also the case, of course, in Brazil with your community health agents. In South Africa, you have different models, but nonetheless, resources in rural South Africa are relatively available. But the question is, how can we repurpose primary healthcare infrastructure, which is historically focused on mother and child health, on TB, on dengue, on HIV, to meeting the needs of the groups who are most vulnerable to, most affected by coronavirus, specifically older people and people with NCDs. So that they, what do you say to these workers who are dealing with a crisis at the moment, have very little bandwidth to take on a new piece of information, so that they at least have some general awareness about older people's needs and sensitivity to their needs? How do you actually put that to them? So, Leon, yeah, you first. I'll shut up, and,
yeah.
I won't interject this time. Sorry about doing that.
Oh, sorry. So I think that's a really important point. What we need to realize is that a primary healthcare team is not disease focused, but it's focused on the person, and it's about saying what are the needs of this person. And one of the things that's interesting is how the HIV epidemic in South Africa has actually strengthened the primary healthcare service team. That there are community health workers. We have a community-oriented primary care model where we have a tiered health service where every single household technically in the country can be visited by a community health worker who can gather data, can provide some information and service. And it's about saying, now that we've got a coronavirus epidemic, what are the absolutely essential services that need to be rendered at this time, taking into cognizance that there are still the ongoing services that need to be rendered. So how do we just repurpose what you're doing? If someone's vulnerable or someone's not able to manage their daily activities, can that healthcare worker assist with, say, washing or bathing because there isn't someone to do that for the person today? Do we get the community health worker to link with social services to make sure that food is delivered to the home. These are the things that I think it does mean that we have to strengthen community health workers. And unfortunately, we've seen a strong focus on secondary and tertiary level services at the expense of primary care services. And we know that tertiary level services have not been able to meet the needs of the crisis. And the only way we're going to deal with the crisis is actually strengthening primary healthcare services. I think what coronavirus has thrown up is how important it is to strengthen primary healthcare services.
Eberhart, and Alex, if you want to text me your response, I will also share that.
Yeah, it's a bit of a commonplace. I basically agree totally with what Leon just said. It's a bit commonplace to say primary care should provide holistic, person-centered care, but that's just what it is. We've been focusing a long time on what we call vertical programs, which have to deal with lactation, pregnancy and childbirth, tuberculosis, hypertension, whereas what we should focus on is on providing the healthcare team, primary health teams, with the means they need to respond to whatever needs their population has. So if I don't know, 1 year ago there was a big drug dealer war in Rio de Janeiro, in Rocinha, and what we needed to focus on were the psychological impacts of the civil war which was happening, and now it's a pandemic. We have to be able to adapt as in universities, as they are migrating more and more towards teaching the students how to understand new content instead of teaching them the content itself. The focus on primary healthcare teams should be on how to adapt to different needs, which do change and will change ever more rapidly in the coming years. So once we can make the shift, this will probably be well equipped to whatever arises.
Peter, I would like to add to what Eberhart has said, and he is in the forefront. He has been a time in favela, which is probably the worst, with very tuberculosis. But we have to consider that in our countries, such as Brazil, life is cheap. We are talking about 5 every single month in Brazil, most of them in this poor community. This is the reality that primary healthcare workers have to work. We have 60,000 plus murders, 60,000 people that simply disappear. That you disappear, it's your body that disappears. And this is the context in traumatized population. Will now have to hear, you have to stay. These messages are hollow in the presence of desperate, frightening person. This is why it is so much more difficult to bring. And at the end of the day, primary healthcare workers will have to deal with all situations which are not easy at the best of the time. Pandemics will bring them to the brink. We have just heard today that Manaus, the capital of the state of the Amazon, the health services have reached collapse. And there are people that say that, oh, countries, the virus will be kinder. We are not the same that we have seen in the winter in Europe. This is not true. To see situations like in Ecuador. Unfortunately, the women from Ecuador migrated to Spain out of poverty to look after all the people in Spain. There's a very big exchange between Ecuador with direct flights to Guayaquil. They them the virus that are now killing their mothers who were looking after the grandchildren. So you see how perverse it is, the twist, that it's the same women that went to Spain in order to make a little money sustain their families in Ecuador, because of the very close ties between Spain and this community back in Ecuador, are now killing the very old woman that were looking after the children of this woman that had gone to Spain. We have to see these pandemics that does just exacerbate inequalities at global level, and yet what we are seeing is the United States threatening instead of strengthening global response by withdrawing funds from WHO.
Okay, Meredith, over to you, and particularly focusing on this issue of primary healthcare and what we can do to use resources that we already have, regardless of all the global injustices Alex was referring to, which I completely buy into. Here and now, in the realpolitik of where we stand, what could be done to enhance the focus of existing infrastructure on the current crisis?
Thank you. Can you hear me?
Not very clearly. Are you as close to the mic as you can be?
Yes. I am struggling with the audio here. Apologies. Okay. Just one very simple, immediate thing is obviously very, very clear guidelines. The guidelines I think are mostly guidelines for, but they're quite without a prioritization, and I think.
Hi Meredith, we really can't hear you. Would you mind if I just take some written responses from you and share them later on the website? Is that okay? Hello? I'll work on the assumption that that's okay, since I can't hear from Meredith at the moment, guys, and I do apologize, Meredith. We clearly, as part of the development of the platform, we need to find a software which is sensitive to variable levels of sound quality and microphone quality, and so that's something we'll try and do next time. One last set of questions for each speaker, and possibly Meredith, if she can join in. Some of the guidance out there for primary healthcare in high-income countries and low-income countries at the moment is actually quite problematic. World Health Organization guidance, technical guidance at the moment, refers to people staying 1 meter apart, which is bizarrely contradicting the 2 meter minimum that just about every other health agent in the world is asking. Why they do that, well, you can only try and figure out. Clearly, there's different sets of guidance about the kind of personal protective equipment that primary healthcare workers should be using, assuming they can get access to it. Should people be utilizing masks, or should they only be using WHO standard PPE? So I'd like you each to give me an example of one thing that we should not be doing or saying in terms of primary healthcare and COVID, possibly generally or with specific reference to older people. That would be even better. So I'll throw the floor over to Leon first, and then to Eberhart, to Alex, and then we'll try and get Meredith back in.
The one thing that we shouldn't be saying, goodness, I'm at a loss. I think we should. Peter, I haven't really thought about what we shouldn't be saying. I think we shouldn't be saying that we should stereotype this illness, that we should blame anyone. We can't blame the Chinese. We can't blame the rich for bringing it into the poor areas. If we're going to play the blame game, we're going to make a mistake. And then I think we shouldn't be saying that there's a drug to treat it. We shouldn't be following the leaders of certain high-income countries who are telling us that there's hydroxychloroquine that should be hoarded, and other drugs, until the evidence comes out that there's benefit of treatment.
And I guess you might want to add antibiotics to that list as well.
Yeah, or any drug treatment until we've got proven benefit of drug therapy or interventions. I don't think we should be telling people to do them.
Eberhart.
And I'll add corticosteroids to that list. And actually, as you said, anything, because so far there's nothing which will really help medication-wise. What I'd say is we shouldn't be saying there's a dichotomy between the healthcare outcomes and the economic outcomes, putting it as if we should take care of healthcare now and leave the economic crisis for tomorrow, or we should think of the economic crisis and not take care of the healthcare system and of the health of those who are now critically ill and will be in the next weeks and months. So we should abandon the dichotomy and know that we should do both at the same time. Actually, we should invest in the healthcare systems, and we should invest in the social structure, in the economic structure that will mitigate the impacts of social distancing and the other necessary measures for taking care of our health now.
Alex.
No, Peter, Alex is not, his connection is not working. So maybe Meredith.
Hi, Meredith.
Can you hear me now?
Yeah. Now Alex is back.
Alex, back to Alex. Sorry, Alex, it's very frustrating. We could hear you when you said, "Can you hear me now?" And then we stopped being able to hear you. Life is like that sometimes, isn't it? Shall we try, Meredith?
Okay, I think that you can hear me now.
Oh yes, we can again. You're just messing with me, aren't you? Go on, over to you. Go for it, Alex.
I was just going to reinforce the confusion we have here. We have come to a state that is pathetic, ideological war. And we have a president who walks around with a flask of chloroquine and says, "This is going to." That is what we have to cope with governors, with politicians, with leaders that have very poor science literacy. They don't understand what is a clinical trial. They want a magic bullet. They have made a mess of the primary healthcare sector, disinvesting on the healthcare sector for the last few years. And now they expect that with a magic bullet, very easy, we are going to.
Alex, I don't know if you finished talking, but it went very quiet. So let's see if Meredith can speak to us. If not, that may be as far as we're able to get. Meredith, are you out there?
I am. I'm not sure. Can you hear me?
Yay!
No, I would just say it's just countries and different localities are really in very, very different phases. It's to be very, very clear on what primary healthcare can do in terms of access to regular services at different phases and getting that clearly communicated to the service providers, but also to their patients as well, because fear, and we've already discussed mistreatment, but fear is also very, very dangerous in this situation, I think. So coming up with good guidelines for what time available, when and how, and thinking through this now as countries and different regions go through different phases.
Peter, can you hear me now? I just want to finish the point that I was making. The point is that we make a huge effort, like the governments of the states of Northeast, most impoverished region in the country. They have made an order and paid for precious equipment to be from China. When the stopover in Florida, it was and the authorities there paid twice as much to keep the respirator and masks. Conspiracy, and there is no way with global that the most devoted healthcare team in any favela in the South is going to cope.
Thank you. Thank you, Alex, so much. And it's exactly 2:30. And as you know, I'm very anally British about my timekeeping. So I think it's the end of the webinar. I would just like very much to thank all our participants for participating and for their excellent questions. I'm hugely grateful to all our speakers who I think have made fantastic contributions and have dealt very professionally with some of our technical glitches, which we will I don't think have next time we have our next seminar. I'm especially thankful to Lucas Sempe, who has been working ferociously behind the scenes to make this work as well as it has done. And I think generally it has worked pretty well. So thank you, Lucas. Please keep it in your diaries for next week. We will be having our second webinar, which will be focusing on an even more challenging set of issues, which will be ageism, ethics, and managing scarce resources. So if you think the questions we were asking today were difficult, just wait until next week. So thank you, everybody. It was a pleasure webinaring with you, and see you next week. Tell your friends. Goodbye.